Okay, hi guys, this is the urinary system and elimination system lecture. Okay, the purpose of that, what was the urinary system's purpose? To eliminate waste from the body, regulate blood volume and blood pressure, and control levels of electrolytes, metabolites, and regulate blood pH. The urinary system is divided into two tracts, upper and lower. Upper is kidneys and ureters. Lower is the bladder and the pelvic floor. Urinary elimination depends on the effective functioning of the upper urinary tract, the kidneys and the ureters, and the lower urinary tract, the urinary bladder, urethra, and pelvic floor as well. So urine is formed in the kidney. The formed urine moves to the calyces of the renal pelvis, the ureters, and the bladder. Urine is formed in the nephron as the functional unit of the kidney. There's a picture of the kidney, the functional unit of the kidney. There's a picture of the glomerulus, the Bowman's capsule, the proximal convoluted tubule, loop of Henle, and distal convoluted tubule. The ureters are about 25 to 30 centimeters long. They enter the kidney. At the junction, there's a flat fold of mucus that prevents reflux of the urine. There's a picture of the bladder, hollow organ serving as a reservoir for the urine. And the urethra extends from the bladder to the opening, the meatus, and in women, it's about 3 to 4 centimeters, and men, about 8 centimeters. And there's the pelvic floor, the vagina, urethra, and rectum, the muscles and the ligaments extending from the pubis to the coccyx. We talked about some exercises that women can do to strengthen their pelvic floor called Kegels. You'll learn more about those in OB again, but Kegels are when they tighten up their pelvic muscles and hold it and let it go and hold it and let it go. The more you can do in the day, you can really strengthen up your pelvic floor. The normal process of urination is stimulated when the sufficient urine collects in the bladder and stimulates a special stretch receptor in the bladder wall. The internal sphincter relaxes, stimulating the urge to go to the bathroom, to void. If appropriate, the brain relaxes it, and then you can go to the bathroom. Factors affecting voiding are developmental factors, psychosocial factors, fluid intake, medicine, muscle tone, pathological conditions, and surgical and diagnostic procedures. Infants can urinate as often as 20 times a day. Preschoolers are able to toilet by themselves, but do not punish them for accidents. School-age children can have bedwetting and uresis. Older adults can have getting up to the bathroom a lot to go to the bathroom. And the factors affecting voiding psychosocial is like privacy. That's really hard when you're in the hospital too. Fluid and food intake and medications. Tone, if you've got a good tone, good vessel tone in your bladder or not, is a big difference. And pathological conditions like diseases of the kidney, the heart, the urinary stone, and the prostate in men. Surgical and diagnostic procedures that affect voiding that could cause some swelling to the urethra after a cystoscopy. Well, I put the scope down your urethra and look around, a spinal anesthetic. I would talk to y'all a little bit about after someone gets an epidural, they'll have a Foley catheter in while they have an epidural, and then when the feeling starts coming back in their legs after they've had the baby and stuff, we take the Foley catheter out, and then sometimes they still can't tell when they need to go to the bathroom because the feeling or they got some swelling down there for a little while. Altered urine production, polyuria is a lot. Diuresis is excessive fluid, and then oliguria is very low urinary output. And anuria is like no output, and that is very dangerous. So we got to have some output, at least 30 cc's an hour. when anuria occurs, you're going to end up on dialysis if we don't get it fixed. So frequency and nocturia, avoiding at frequent intervals, more than 4 to 6 times a day, or 2 or more times at night. Urgency is a strong desire to avoid with or without the presence of urine in your bladder. Dysuria is avoiding that is painful or difficult associated with the bladder infection usually. It can also be associated with if you've got blood in your urine, and again with an infection. Enuresis, involuntary urination in children beyond the age when bladder control is normally acquired. So urinary incontinence is normal only in infants. Stress incontinence happens mostly to lots of women when they get weak pelvic floor muscles, had a bunch of kids. They have some leaking when they cough or laugh. They can have urge urinary incontinence when that's the inability to stop peeing, and then mixed symptoms of both. Urinary incontinence is when it flows like your neurogenic bladder. They can't even tell how full their bladder is. So we talked about, you can see how much urine is in there. If you have a bladder scan machine like they had showed you on that's really good. But if you don't have one, you can have them go to the bathroom and then do a straight catheter and see how much urine is still left in their bladder. On assessment, on nursing history, we do normal voiding patterns, appearance of urine. When we're taking that history is when we try to get as much good history from them as possible. If they have an ostomy or not, if they have any factors that affect their elimination pattern, like a history of several bladder infections or something, or kidney infections, physical assessment, hydration status, percussion. You can do a percussion on the kidneys and see if there's any tenderness. You can inspect their body and see if there's any swelling, discharge, or inflammation. Urine is 96% water, 4% solute, so like ammonia, creatinine, and uric acid. And there's the normal contents in urine and the abnormal contents of urine. The abnormal things that shouldn't be in there are the albumin, bilirubin, glucose, ketones, microbes, blood, and white blood cells. Those things should not be in urine. And so assessing urine output, I've told y'all, we call that the Dutch hat. We put it in the toilet stool to catch the urine so we can do a good INO on them. Some diagnostic tests they can do is blood urea, nitrogen, and creatinine. They can evaluate renal function from checking that. And then here's some diagnoses that have to do with urination: impaired urinary elimination, readiness for enhanced urinary elimination, functional. And so you guys can read through those diagnoses. And the etiology from other problems, like, of course, you probably would have a low self-esteem if you were wet all the time and you couldn't control your urine, or a self-care deficit. If someone's having to take care of you, the risk for caregiver role strain. So the plan would be to maintain and restore a normal voiding pattern. And ways to do that: prevent risks such as infection, skin breakdown, fluid and electrolyte imbalance, and low self-esteem. The big thing in the hospital is trying to get them to have some privacy. We can make signs for the door if they're able to safely go to the bathroom without us worrying about them falling. And if we are in there with them, we can still make a sign for the door while we're helping them and try to give them as much privacy as we can. We can contain urine with appropriate devices, catheters, or ostomy. And then when we're doing a home care, we kind of see what kind of home they're going into, like with somebody, their own home, and then talk to them about the caregivers and if they're going to have somebody come out there and to their house like 2 or 3 times a week. We try to maintain normal urinary elimination, promote fluid intake, maintain normal voiding habits, and assist as needed. So trying to get them to drink 8 ounces of glasses of water a day, frequent voiding every 2 to 4 hours. A lot of women can't use any kind of bubble bath or any kind of soap. We need to wear cotton underwear to keep us from getting a bladder infection. Girls and women always need to wipe from front to back. And take showers rather than baths if possible, because you can get a bladder infection from a bath really easy. So managing urinary incontinence is providing incontinence training, do bladder training. We can do pelvic muscle exercises. Those are the Kegels. Maintaining skin integrity. You know, so like if you're the nurse and they're your patient and they're wet a lot, things that you could do to keep them dry in between, like if they have a catheter, changing their diaper or whatever, like a pad that they've got often so they won't get skin breakdown. And then managing urinary retention. And the catheters are all, insertion of catheters is the most common cause of a hospital-acquired nosocomial infection. There's that word again. So we have to be very careful when we're doing a catheterization, and we'll be doing those. So not to contaminate the end of the catheter when we're putting it inside their body. People that have a catheter left in nursing interventions that we can do encourage large amounts of fluid intake and foods that create acidic urine and give routine perineal care. And again, prevent contamination with feces. Nursing interventions with catheters are still doing a change the tubing in a catheter when necessary and maintain a closed system. Always use good hand washing techniques. Make sure the tubing is not kinked. And it's really easy. It can get that way when they're rolling around in bed and moving around. It can get kind of kinked, the tubing can. Make sure it's well sealed and closed and draining. If you're going to remove a catheter, you obtain something to put it in, lay them down, and then you take out the secure device. Sometimes it'll be taped on their leg or it have a little fastener on their leg, and you get the water out of the balloon after all the water's gone, and then you can take the catheter out. So nursing interventions with people with catheters, you can remove it, document that you removed it, and then write down what time you removed it so you can monitor when they had their first void after the catheter was out. And then remember, I said nursing can be fun. We really are doing good at clinical, I feel like, with teamwork. And I hope you have a good teamwork all your career in nursing. It really helps when you have people that you can trust, people that you can talk to on your team. And then you have to work with all of them though. So sometimes it's not that way, but it can be really, really fun. And some people have to go home with self-catheter, learning how to self-catheterize. And I was telling you, one of my friends had surgery and she had to go home and do this for a couple of days. We try to leave the catheter, of course, closed. And then the suprapubic catheter, it just goes directly through from the abdomen right into your bladder on the outside of your body. And it's inserted surgically. And you also maintain a patent system, make sure it's draining, keeping the skin around it clear and clean. And there are some more things that we have so that patients can't have: urostomy, nephrostomy, ileoconduit. And there's a picture of a urostomy and a nephrostomy. That's the bag on the right, directly into the kidney. And the ileoconduit, and the pouch, and the neobladder. So that's INO on note any changes that the patients had in their color, odor, or clarity. Always follow your hospital protocol when you're taking care of these people. Common medications that we can take with diuretics, we want to check the potassium. Remember, when a diuretic has you pee a lot, it'll drain fluid off of you when you have lots of edema. But you want to check your potassium then, because even like when you have a virus and you're throwing up a lot and having diarrhea at home, you can get low on your potassium. Be sure and check your blood pressure, because you can get hypovolemic, like you're losing a lot of fluid, too much fluid, and then you can get hypovolemic. So Be sure and check your blood pressure. Cipro is a really good medicine for antibiotic for a UTI. And there's just an example of results from a urine test. And then y'all had answered these on your homework for me, the 3 purposes of the urinary system and all that. That's just kind of like to help you review. And there was some more. Okay, and then we went into the bowel, and I'm going to get my book and my the book I use sometimes, the paperback, the study guide, and see if it's got anything that might help you kind of review. I think we covered most of it. Yes, it's talking about the dysuria and anuria. The anuria is the no urine. So the dysuria is painful urination. Anuria, you really don't want to have that. You want to have that. That's a life-threatening situation. You could end up on dialysis. So you want to make sure they're having at least 30 cc's an hour of output all the time. So you want to make sure that, and if they are having dysuria, you can talk to them when you're admitting them, or if they happen to be your patient, then they start having dysuria. That's painful urination. So it can be caused from a bladder infection. It can be caused from like a manipulation, like if they had they had a lot of vaginal checks that day in OB, or they got catheterized, it can be painful for a little while, but it should get better if it's not an infection. And it's also talking about nocturia, about having to get up at night and go to the bathroom. A diuretic increases that. So we had talked about if you were going to give somebody Lasix, not to give it to them before they go to bed, because then they'll have to get up and go to the bathroom a lot and not get much rest. And if you're trying to help somebody remember to go to the bathroom, some of these people in our facility that were doing clinical, they can go to the bathroom by themselves. Well, they like to have somebody in there with them, like if they have a walker, especially, of course. But try to get them to go and reminding them like every 2 hours to go to the bathroom. That kind of helps them get into a habit and trains their bladder to go like every 2 hours, and then they maybe could have less accidents and less skin breakdown. And talking about the normal characteristics of urine, what's normally in urine and what normally isn't. Remember that urine is mostly water. And that the kidneys are the ones that get the waste, filter all the waste. We try to get the patients to drink a lot of water. One place says 8-ounce glasses of water, at least 2,500 cc's every 24 hours. And you can find them, if you can find them, instead of saying, well, drink 2,500 cc's or drink 8 ounces of water, you can find them a cup. My doctor told me to do that with myself and find out how much it's in there, and then just be sure and drink that cup up to and it's got marked on there how much is in there, and then it's an easy way to keep track, especially if they're on INO or you're trying to keep them on INO. And so normally urine has a lot of water in it. It does not normally have things in it such as glucose or blood or protein. If it's got blood in it, sometimes you can see the blood in it. Lots of times you cannot see that it has blood in it, but on their urine test, it'll say it's got blood in it. So they've got a bladder infection or a kidney infection. If it's got ketones in it, that means that they're dehydrated and the body is starting to break down some things it's not supposed to break down. So it's got ketones in it. If it's got protein in it, that's not good if you're pregnant, because that can be like a sign of preeclampsia. You guys will learn about that. So those things should not be in urine. And when they were trying to help the people build up their pelvic floor, we can have them do the Kegel exercises. I think some people say Kegel exercises. I just always say Kegel. It's Kegel, where you have them. It's like if you were peeing or avoiding peeing, and then you stop in midstream. It's just like pulling those muscles up, holding it, letting go, pulling it up real tight, and holding it and let it go. And that can really help some people strengthen up those pelvic floor muscles, and it'll help them with if they have stress incontinence from coughing or laughing or something like that. If they have too much glucose in their urine, that could be related to diabetes. They should not have any glucose in their urine at all, and they shouldn't have blood. If they've got blood, and that's a sign of infection for sure. So getting them to drink a lot it helps them a lot. And then, reviewing what stress incontinence is and what urge incontinence is. Stress incontinence is when, like we talked about, you cough or you laugh and you have a little bit of leakage. Urge incontinence feels like you have to go right now. Very strong feeling that you have to go right now. Sometimes when you get somebody admitted, you try to, of course, find out what medications they're on. Sometimes they have a list, and that's a great thing. Sometimes they don't have them all. Some of their medicines can change their urine's color drastically. I had talked about having their urine. Sometimes their urine can be like an orangey looking, and that is usually from medication like pyridium or something that they're taking for a bladder infection. But it really can look pretty orange. Okay, and of course, the nephron is the one in the kidney that makes the urine. And we can always do a perineal care if they've got the catheter in. We need to be sure and do that. Try to keep it as clean around there as you possibly can. When you're catheterizing someone, trying to keep it as sterile as you possibly can so you don't give them an infection. Okay, and then I went to the bowel. This is the bowel. And that is the stool squat. I thought that was cute. I think Miss Newland had that slide. People don't want to talk about poop much, or it's embarrassing to them or something. But you get kind of used to it, where it doesn't seem like a bad thing to talk about. But anyway, we have to, when we get a new patient, we try to find out if they're normally constipated, if they're normally having diarrhea, and what's their normal, or what's changed because they're sick. And so the elimination of waste products and digestion from the body is essential to our health. And so the main function of the large intestine is to absorb the water and the nutrients and eliminate the fecal material. Most of the waste products are excreted within 48 hours of ingestion. The chyme is the word that they use when the food's all chopped up and it's mixing as it goes through your intestines. It's chyme. And the large intestine, the mucus in the colon protects the lining from the acid. And there's 3 types of movements in the large intestine. Just remember what peristalsis is. Peristalsis we had talked about. It's the wave-like movement produced by the intestinal walls, and it moves the things along. And so when you're listening to bowel sounds, that's why it's so important. After surgery, you listen to their bowel sounds, and a lot of after surgery, they were NPO for a while. Well, in OB, they let them eat pretty quick. I mean, like a regular diet. And so if you've got a patient that is not moving, won't sit up for you or dangle on the side of the bed, won't move at all, and then their family's bringing them hot dogs, hamburgers, and I've seen it happen so many times, then you got to get them moving, because if they don't have any bowel sounds, if air's not going to move through their intestine yet, then food's not going to move through their intestine, and they're going to get distended and have to have maybe even an NG2. I've seen that once. So try to get them moving, try to get them to sit up as you can, and help them get that peristalsis going after surgery. The rectum and the anal canal, rectum is 4 to 6 inches, anal canal 1 to 2. There's some folds within there, and they help retain the feces into the rectum. You can have internal hemorrhoids and not even know it, or your patient can have internal hemorrhoids. Sometimes if you have a little blood when you have a bowel movement that's kind of like more bright red, sometimes you'll have it's from an internal hemorrhoid that you don't even know that you have or that your patient has, like when you do an enema on them. The frequency of defecation, pooping, no telling what your patient's going to call it, is extremely individual. So it can vary from every day to several times a day. Feces move through the canal and are expelled through the anus. And so that's why we try to talk to them and see what's normal for them. Here's a stool chart. You can kind of ask them. Like, when you go to the bathroom, is it pretty, is it like, don't use the word normal, because normal could be, there's not like, we're all different, you know? So you could say, are you constipated? Is it hard to go to the bathroom, or is it easy to go to the bathroom? Is it pretty soft? Sometimes is it hard? Or does the doctor tell you to eat that more fiber, have some fiber cereal or fiber in your diet? And fecal elimination problems, like the fecal impaction. I told you about that. What was my experience in nursing school was the fecal impaction. This guy was totally impacted. So a symptom of that was like a little bit of fecal seepage, a little bit coming out. And they're distended in their abdomen. Of course, they don't feel good. They feel nausea. They can even vomit. They don't feel like eating. They just feel totally bloated. And the cause of that's constipation, maybe a poor diet, maybe they had a barium enema, and the barium can cause it. And so you can try giving them an oil retention enema, cleansing enema, a suppository. And if all that doesn't help, then you have to give them, you have to help them with impact. We have to help them with getting it out for them. Like we had talked about that too. So all right, as you can see, those slides are doing the same thing they did in class. Let's see if I can fix that. But just grab your PowerPoint, and I hope you have it, that you already have. Okay. I think I got it back here. Try to slowly get this sorted. No, won't do that again. It's just gonna do it anyway. Okay, we'll go backwards then. Okay, we're going to be talking to them about giving them a normal place to go to the bathroom. And they're not, privacy is so important. It's really hard to go to the bathroom on a bedpan. For the ones that have to use a bedpan, it's so hard. But remember, if you do put somebody on a bedpan, you're going to sit them up as much as you can. You can't lay them down and expect them to be able to go to the bathroom. It's hard enough. That's a bedside commode for the ones that don't know. And we can put that by their bed, where it's very easy just to get them up on their bed and go back to, oh my goodness. I'm sorry, you guys. Anyway, to help them with getting up right there by their bed. Okay, I'm just going to go backwards, I guess. We're going to be talking about ostomy some more in the lab again too. So. We will be talking about enemas. I don't know if any of you guys have ever had an enema. They used to give these really, really big enemas in OB. They call them the 3H enemas. High, hot, and a lot, but they don't do those anymore. But a fleet enema is pretty small. It's just like a little bit of fluid that goes in there. We'll be talking about those. And then there's a soap suds enema, an oil retention enema. But they really, really are helpful. to some people. And laxatives are very helpful if they're not overused. Some people will overuse them, and then your body just gets dependent on that and won't do its natural thing by itself. So you need to teach them about not using too many laxatives for sure, to increase fiber in their diet. So be sure that you would know how to help them increase fiber in their diet. And they can take stool softeners if they have to. I mean, a stool softener is better, like a Colace. You'll see those in the hospital pretty easy. Those are pretty mild though, but they will help you go to the bathroom instead of a laxative all the time. Let's see. And I'm going to look in our review book as well too. Okay. All right, so that it says it's on chapter 47 for the bowel. Let's look at that. Just making sure that we've got everything covered on. Okay. So the small intestine is divided into three sections: the duodenum and the jejunum and the ileum. And the duodenum and the jejunum absorb the nutrients from the small intestine, and the ileum absorbs the vitamins. And so a lot of the digestion takes place in the small intestine. The large intestine is mostly in charge of getting rid of the bowel elimination, getting rid of our stuff that we don't need, and by ways of peristalsis. All right. So be sure you know which one, like the small intestine, what it does, and the large intestine, what it does. And then factors that, this book's going over the same, like factors that influence bowel elimination: age, like infants have a smaller stomach than adults, of course. Adults have a decreased chewing ability. Partially chewed food isn't digested as easily. Muscle tone in the perineal floor on an adult is hard, makes it difficult to go to the bathroom and have a bowel movement sometimes as well. Diet, fluid intake, even though if you don't drink enough fluid, it can help you be constipated or mess up your bowels. Physical activity. Physical activity helps promote peristalsis. That's why they want someone to get up, or like encouraging early ambulation. As soon as they feel like it, they can walk. That will help go to the bathroom so much too. Psychological factors, prolonged emotional stress can impair any part of the body. Some people, it hits in the bowels and they can have diarrhea all the time, or they can be constipated. Some kind of medicines can make you constipated. And then some medicines like the laxatives that we talked about, but they just need to avoid regular use of laxatives for sure. Okay. When they're on medicines, another thing that be sure that medicines can cause other problems, like the pyridium for your bladder infection can cause your urine to be orange, and antibiotics can cause you to have diarrhea. So medicines can actually affect our stool, of course, but antibiotics are still very, very good, to help us. So if you are giving somebody a stool softener or a laxative, what would you be sure you want to ask them before you give it to them? Like, what if they're on it PRN, or they've been like really constipated, maybe you were off work a couple of days and you come back and you see it on there, you're gonna go give it to them. Be sure to ask them if they've had a bowel movement. I mean, what if they just had a big old bowel movement and they don't really need it this time? And if they say they've had a bowel movement, I learned the hard way to ask them if it was a small bowel movement or a large bowel movement. So was it just like a little bit and they still need it, or was it a pretty good large one? So when you admit them, see if they can tell you when it's the last time they've had a bowel movement. That's really, really important, because if you get somebody admitted and they don't have a bowel movement for 4 days, and it's already been 4 days when they came to you. So be sure, if they're alert and they could give you a pretty good history, try to find out when's the last time they had one? And a lot of people have, some people have problems with gas and they can't even control it. There's so many, these people at work used to put this medicine in the beans when they would make beans for work. So that would control people's gas. Of course, it didn't control everybody's gas, but you know, if the more active they are, that will help with decreased gas, having decreased gas. And if they're taking probiotics on a daily basis, that can help decrease the gas. Chewing gum, chewing like vegetables and using a straw, chewing gum, they all cause more gas. Like I was thinking about before I saw that gum one, it's about also mouth breathers. Mouth breathers, people that breathe from their mouth can have more gas. But food that causes gas is vegetables like broccoli or dark green vegetables like artichokes and stuff like that can and if you use a straw and if you chew gum, I mean, all that stuff can make you have more gas. So don't try to teach them if they try not to have gas, all the things that they could do to make it better. So I think we've just about got to the end. We talked about if you're on a bedpan, you don't want to lay flat and try to use that bedpan. You want to try to sit up as much as you possibly can. If they're asking you, if they're getting a test on their bowels, if they have to have a colonoscopy. I don't know if any of you guys have had to have one, but the worst part to me was you have to drink this bunch of stuff to completely empty your bowel as soon as you can. And you try to be sure that you empty it because they kind of put you under anesthesia. And if they can't see in there, it was all for nothing. So make sure that you drink the stuff and make sure that when they put that, they're going to insert the tube with a scope on it up your anus, up into your intestine, and they're going to look around in there. They're going to see if they see any polyps or diverticuli, and especially if your family's prone for cancer, they're going to be looking. So if they ask what a colonoscopy is, that you could tell them that that's what it is. You tell them how to do Kegels to help them, and we talked about that. We talked about getting on the bedpan. Also, when someone's trying to needing to go to the bathroom, and like if they teach them when you're doing some teaching with them, that'd be an idea. When if you've been giving them maybe a Colace or a stool softener, and they feel like the urge to go to the bathroom, and you know how sometimes, of course, it comes when you've got company or someone just walked in the room, maybe the doctor's coming in there to talk to you, but tell them when they feel that urge to go to the bathroom to go, because that will help them. If you miss it, sometimes you just get like reconstipated again. And then we'll talk about on enemas, when you're giving somebody an enema, I'll be talking about that with you too, but you want them to you'll give them some water in their rectum, and they need to hold it for a little bit, because that's what helps them so much. It's when they hold it a little bit, and then it will stimulate them, hopefully, to have this bowel movement and not end up constipated. So that is very helpful to them as well. When you're trying to check them, they usually have these cards on the unit to check for an occult blood in their stool. If they have any, like if they come to you and they tell you that they've been having some very, very black stools, like sometimes very black stools can mean blood that's in there, that you can't look at it with your eye and see that it's bloody. They can do an occult test, like a hidden blood test on there, but it's a little card, and you catch some of their bowel movement, like in a Dutch hat or of your own, if you're checking your own, and then you take a little, like a stick or a tongue depressor, and get a little bit of that poop on there, close the card, and then you flip it over, and there's some drops that you put on there, and it'll tell you if it thinks that they're having some bleeding or not there. So, anyway, we want to help them as much as we can, of course, to feel the best that they can. So if they're having any kind of issues with bowel or bladder, we sure want to help them, your patients, as much as you can. So, all right, we'll just look over your PowerPoints and your handout that you have. And I sent those to you on email because Blackboard was getting so full, but I sent those to you on email. But if anybody needs any kind of handouts to study from, I still have them. I still have them here, so I'll be glad to get them to you, of course. All right, well, you guys have a good evening or good day whenever you're listening to this, and I will talk to you later. All right, bye.